Good afternoon, and thank you for joining us today for Developments in STD Testing Needs, a collaborative discussion for practitioners and laboratorians hosted by HCET with presenters Dr. Jessica Dalby and Dr. Alana Sterkel. My name is Carrie Baranowski, and I'm the Family Planning Reproductive Health Specialist at HCET. I'll be moderating this webinar today. Let me briefly introduce you to healthcare education and training. HCET's mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. HCET is an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health, education, training, and care is a fundamental right. For more information and to keep up to date with HCET events, please be sure to follow HCET on these various social media platforms and visit our website. I'll quickly cover some housekeeping information. If you would like to receive NCH for this webinar, please complete the form that was sent with the login information and email it to kbradford@hcet.org. A link to complete an event evaluation will be sent to you via email following this webinar. Your feedback is greatly appreciated. Archived presentations and a list of upcoming events can be viewed on our website. If you have any technical difficulties during this presentation, please contact Jen Stevenson at the phone number or email listed on your screen. In order to receive NCH for this webinar, participants must attend this entire webinar, complete the entire evaluation, and submit the NCH form to HCET. Our presenters today do not disclose any actual, potential, or perceived conflicts of interest. Throughout the presentation, we encourage you to send your questions via the chat box. To submit a question, hover over the main screen, then select the blue chat icon. Once selected, the chat box should appear on the right side of your screen. To send a question at any time during the presentation, please send it to all panelists. This ensures everyone behind the scenes can view your question. We will hold all questions until the Q&A portion of the presentation, which will come at the end. Now I'd like to introduce you to your two presenters today. Dr. Alana Sterkel serves as the Assistant Director of the Communicable Disease, having technical difficulty with the slides, thank you. Dr. Alana Sterkel serves as an Assistant Director of the Communicable Disease Division at the Wisconsin State Laboratory of Hygiene. She received her PhD in Medical Microbiology and Immunology from the University of Wisconsin-Madison and completed her Clinical Microbiology Fellowship at the University of Wisconsin Hospital and Clinics. She is certified as a specialist in microbiology by the American Society of Clinical Pathology and as a diplomat with the American Board of Medical Microbiology. Dr. Sterkel pursues research into infectious disease and human pathogen interactions. Her responsibilities at the state lab include technical oversight of the Communicable Disease Division, development of new test methods, outreach and educational activities, and outbreak and bioterrorism preparation and response. Dr. Jessica Dalby works with the economically and racially diverse population at a federally qualified health center in Madison, Wisconsin. She is also faculty in the Family Medicine Residency Program at the University of Wisconsin. She earned her medical degree in 2008 from Baylor College of Medicine in Houston, Texas, and completed a family medicine residency at the University of Wisconsin-Madison in 2011. She completed an academic fellowship within the University of Wisconsin program prior to joining the faculty in 2012. From 2013 to 2017, she was the medical director of the Get-LARC program, focused on teaching resident physicians skills in managing long-acting reversible contraception. In 2017, she became the medical consultant for sexually transmitted diseases with the Milwaukee Health Department. Without further ado, I'll be turning this webinar over to Dr. Dalby and Dr. Sterkel. Thank you.
Welcome. My name is Erin Bowles, and I'm the Wisconsin Clinical Laboratory Network Coordinator at the Wisconsin State Laboratory of Hygiene. And I just want to start today by welcoming all of you to this jointly sponsored HCET and WCLN webinar, Developments in STD Testing, a collaborative discussion for practitioners and laboratorians. We really thank you for joining us today. And now I'm going to be turning the microphone over to Dr. Dalby.
Thank you. This is Jess Dalby. So my goal today is to give, from my perspective, is to give the clinical perspective on these testing updates, and I'm thrilled to be working with Dr. Sterkel, who will give the lab perspective on these updates. To start with, just to review our objectives briefly, number one objective is to take a break from thinking about coronavirus for an hour. And number two objective then would be to focus specifically on STD updates. So we are going to focus some today on extragenital testing. We're also going to be talking about self-collection in extragenital testing. We will touch on some of the implications of Mycoplasma genitalium, a relatively new STD that we are able to test for. And then we'll spend some time talking more about testing and treating males for trichomoniasis, as well as from a lab perspective, also focusing on what are the FDA newly approved tests for these different infections. So just as a brief background, as I'm sure everyone who's tuning in is aware of, STDs continue to increase across the US. So the CDC stats, the most recent stats are from 2018, and you can see across the board in all area, in all the regularly tracked STDs, rates continue to increase. Locally in Wisconsin, our data also goes up. You can see we have Wisconsin data from 2019 is available. And you can see, that the market increases even between 2018 and 2019. So the percentages along the right side of your screen here are showing the percentage increase from 2015 to 2019, but you can see, we're continue to experience market upswings in trackable STDs in the state as well. And these STDs do not affect everyone equally. So we know our Black community, as well as our Native and Hispanic populations, are especially affected by increasing rates of chlamydia and gonorrhea. So these are rates per 100,000 population based on self-identified racial data. So, how can we, as clinicians and laboratorians, work together to counter these high rates, both of disparities and also thinking about addressing these continuing up-climbing numbers of STDs in the state? So, one thing that we're going to focus on today is the importance of extragenital testing. So specifically, when we talk about extragenital testing, we're talking about collecting samples from the rectum and the pharynx. Remembering the 5 Ps of sexual history, practices, we say at the STD clinic, if you use it, we're going to test it. So, making sure you're getting that history as a clinician is really important to be screening adequately as well. There is well-defined recommendations from the CDC about extragenital testing for men who have sex with men. They've had plenty of studies that have clearly shown that at least 1 in 8 MSM has an STD in the throat or rectum when they are screening an asymptomatic population. And again, often there's no symptoms, and having these type of infections also increases the risk of HIV transmission. So we know in MSM that extragenital screening is very important. But we've actually, seen good data that supports that in all comers, extragenital screening is important. So this is some data specifically looking at gonorrhea positive clients at the Keenan Health Center, which is the City of Milwaukee Public Health Clinic. So in this graph, what I'd like you to focus on here is that, over this time period, in all comers here, so, here's our MSM population where you can see if the gray bars are the gonorrhea infections that were only detected because extragenital screening was performed. And you can see in the MSM population for gonorrhea, 13% of pharyngeal, 26% of rectal gonorrhea was only detected because those areas were screened. But even in men who have sex with women and women who have sex with men, you can actually see in women who have sex with men, both pharyngeal and rectal screening, that a quarter of gonorrhea cases would have been missed if extragenital screening was not performed.
Hi, everyone. This is Dr. Alana Sterkel. I'm really happy to be able to join you guys today. We're going to be switching back and forth our slides here as we move forward and make this a real collaborative discussion between both clinicians and laboratorians. You can see me here in the video. I'm also joined with Erin Bowles, so I'm wearing my mask appropriately here. So we're going to be moving through these slides on the different parts for each of these sections. So for extragenital chlamydia and gonorrhea, taking that same data from local data that Dr. Dalby just shared, we can look in a little bit further for both chlamydia and gonorrhea are present in both body sites. So our last data showed gonorrhea in both the pharynx and the rectum, but you can also find chlamydia at both body sites. In this particular population, this was an MSM population where they were looking for rectal or oral chlamydia or gonorrhea. It is noted that there is generally less chlamydia in the pharynx compared to gonorrhea, but it is still present. It is still worth testing this body site for this organism. Another interesting thing to note here is that most of the testing for chlamydia really is based on molecular methods, nucleic acid amplification tests, or NAAT. And what we're looking at here, you can see it's fairly comparable whether they use that specifically, called it out or not. While gonorrhea has other test methods available for it, however, when they use the nucleic acid testing method, the NAAT method, you're more likely to detect gonorrhea at these body sites. So something to keep in mind. Next. So very exciting. Our topic really centers around advancements in STD testing. So it's not new that people have been performing sex acts in body sites extragenitally, but it is new to be able to have FDA-approved test methods at these sites. So we can now start providing care for these patients. There's clearly a need for it. So as we're going along, I'm going to give you little updates of what's going on in the lab, really focusing on what's FDA approved. So for oral and rectal testing for chlamydia and gonorrhea, there are now 3 different platforms that have FDA approval for this testing. This is the Hologic Panther, the Roche Cobas, and the Cepheid Gene Expert. So if you have these instruments already in-house for the Laboratorians, or if your lab that you're connected to for our clinicians, that this may be already available for you if you can do the validation. Next.
So talking again about the next kind of topic is self-collection. So there has been, self-collected vaginal swabs. There's been good evidence for doing that, and I hope many of you are already doing vaginal, self-collected vaginal swabs in your center. This study back in 2012 showed that in a high risk, so an urban sexual health center, a high risk population, where they had a 10% chlamydia rate, self-collected swabs were actually better than clinician-collected endocervical swabs. So you can see here 97% versus 88%. So if, in this setting, they would have missed 9% of infections. And women really reported that these swabs were easy to do, and many preferred this method. So in my clinical practice, I both teach residents and myself practice to ask women to do a self-collected vaginal swab. And that in women, again, is preferred over even the urine sample. There is also similar data for men, actually, in self-collected penile meatal swabs. So again, here they showed that men doing a self-collected swab compared to a urethral swab was also very good. And again, many men were also reported the same thing, easy to collect, and they were willing to collect their own sample. What we know about offering self-collected extragenital tests is that when you offer it, actually often more people are then willing to test. So this is a study where they implemented self-testing for rectal and oral sites at an urban HIV clinic. So again, a high-risk population. They were testing asymptomatic clients, so people without symptoms. They were offering for them to test themselves. And actually, just by offering self-testing, they increased their the number of clients willing to test by a third. So they had a third more clients that were willing to do these tests. And they therefore detected a whole lot more gonorrhea and chlamydia. So you can see in these populations that their rates of gonorrhea and chlamydia detection went up by 50%. The vast majority of participants were able to collect samples appropriately, and the vast majority rated the self-testing experience as acceptable. So looking more about, how accurate is a self-collected rectal swab, there's been good studies among, again, high-risk men and women who reported receiving rectal intercourse. So again, they collected their own samples, and then actually they had clinician collected samples as well to see, are these tests accurate when people do it themselves? And absolutely, the concordance rates was 98%, 98 to 99% in both these high-risk populations, in both men and women who were doing self-rectal swabs. And again, in both populations, the majority preferred to do their own swab. Similarly, it seems like doing a pharyngeal swab may be a little bit more difficult. Like, how do you swab the back of your pharynx? Doing a rectal swab seems pretty straightforward, but what about pharyngeal? So this has also been studied, again, using a high-risk population of men who have sex with men in a San Francisco STD clinic, almost 500 patients. And again, they compared clinician-collected versus patient-collected testing. Their rates actually were, it seems like, fairly low for gonorrhea and chlamydia in a high-risk population, but the testing results of patient-collected swabs were very good here as well. So again, people can accurately swab their own pharynx and rectum.
So what kind of testing is currently FDA available? Well, I think many of us are already testing for self-collected vaginal samples, and this is becoming more and more available as a widely available and interesting target for different clinicians and patient types. So there's 6 different platforms listed here that have these combo kits where you can simultaneously detect for chlamydia, gonorrhea, Trichomonas, Mycoplasma genitalium, and then most recently we now have 6 different tests available on a single swab type on the Panther. You can also test for candidiasis and bacterial vaginosis, all from the same self-collected swab. So this has really gained in the ability to use this sample type, and hopefully will gain in the ability to reach those populations that might not otherwise seek care. Now, this is slowly starting to grow as more companies are recognizing that there's interest in this and that people want to bring on this testing. Self-collected penile meatal swabs are now FDA approved on the Panther and the Cobas for Mycoplasma genitalium. However, next please. There are no FDA-approved oral rectal self-collection tests yet. I've heard that some are in the works. There's certainly a lot of interest, and this is gaining momentum. But if you're able to communicate your interest to vendors as they come through and have those conversations with you, I think that helps to speed up the availability of these kinds of tests.
So something that I have heard people ask at conferences before when we talk about, you really should be swabbing every site that somebody's using, a common comment is to say, well, that's really expensive for our clients. I mean, NAAT tests can be expensive, and now if we're doing both, for a female, for example, who reports rectal and oral sex, if we're swabbing her throat and her rectum and her vagina, what kind of cost is that going to be? So, I've heard people talk about at conferences saying, well, at our site, we swab all 3 sites and put them in the same container to get it. So what about pooled specimens from multiple sites? There was a study that looked at this. Their technique was a little bit different than what you would standardly do if you were, well, it's not standard to collect multiple sites in one test tube, but, in this particular study, what they did is they collected the 3 sites, they wanted to have both the results from the sites individually, and then they also spun those sites, took a sample, an aliquot from each sample, and put them into a single vial to see like how good is it if we combine these into one. You know, again, the rates in this, the rates of infection in this population were 6% for chlamydia and 3% for gonorrhea. And as we've been talking about already, they found that if they had only tested vaginal samples, they would have missed 40% of chlamydia and they would have missed 60% of gonorrhea in this case. But again, the important thing here was that of the women who were positive on the non-pooled samples, there was 5 cases out of 42 that would have been missed by pooling the sample the way that they did it here.
Yes, this is a really interesting topic, and I think certainly something worth our clinician laboratorian discussion today, that this kind of study and the other studies that we've talked about so far that don't have FDA-approved tests were really done in a research kind of environment, and many of them, when you're looking at prospectively collected samples from patients, might require additional oversight. We'll talk about here in just a moment. I think one of the things to really think through here is pooling samples has been used for many years to try to optimize your resources. If you're trying to reduce costs, if you're trying to make reagents go further, that this really does have some real benefits. Next. So in the right setting, pooling can be useful to maximize limited supplies, but there are some limitations you should be aware of. Pooling dilutes the sample. So they generally suggest that you don't pool more than 5 samples together if you're doing multiple patient types. In the last study, I think it was really interesting that it was 3 swabs from the same patient. Some other methods that might be employable would be 3 different swabs all put into the same tube, so you're not diluting out the sample from putting it into 3 different liquid tubes and then combining the liquids. Other options might be using the same swab, but I would certainly recommend starting at the top and working towards the bottom if you're going to go that route. There is some important things to think about with pooling. If you're pooling multiple patients together, because of the need to test the pool, if you test the pool and everything's negative, everything's negative. If the pool is positive, you then have to take the pool apart and test again for the positive to get that result for an individual. However, if it's the same patient, you might not need to do that. Generally, if you're pooling multiple patients together, you want to do it when a prevalence is less than 5%. Otherwise, you have to take apart all pools and retest them. And it really is not cost effective anymore. This can be challenging for some lab information systems to deal with pooling, so not every lab is capable of doing this, and pooling is not generally approved by current FDA assays. The biggest takeaway I'm hoping that we can have from this whole discussion, press next, is talk to your lab. Please don't just immediately start testing your patients on all these different sites and pooling samples without consulting with your laboratory. Every sample that has to go into the lab has to be validated as appropriate for their test system in their laboratory. As much as possible, we like to do FDA-approved tests because it eases the ability for our lab to do these kinds of validations and make sure that we're giving you the best quality testing. So if you're interested in doing these kinds of studies, some labs are open to doing what's called a lab-developed test, which would be what we're seeing in these studies and for the different kinds of pooling things we're talking about. Next. So a lab-developed test, just to be kind of make main points on this, requires much more extensive lab validation, more testing to prove the test works appropriately. It may also require IRB approval for human subject research, and this can be expensive, time-consuming, and has HIPAA implications. And overall, the whole thing for lab-developed tests tends to be more time-consuming and expensive. And that's one reason I wanted to focus on why so many tests are now coming to the market that do have this FDA approval. So not all labs have to do lab-developed tests. However, I would encourage the labs on the call as well, recognizing that there is some need for this and that it can be slow for things to come to market. If you're able to do lab-developed tests, have those conversations with your clinicians and consider bringing on high-value tests for your patient population.
So we'll switch gears here to talk now about Mycoplasma genitalium. So, you know, Mycoplasma genitalium has been around, but gaining kind of awareness over the past few years. You know, symptoms are typically similar to chlamydia. It most commonly causes nonspecific urethritis symptoms. So in men, penile discharge, burning, itching, irritation. and can also cause cervicitis and possibly also PID. Again, it is common in the urogenital system. It is also found in the rectum. It is very uncommon in the pharynx. Some prevalence in a general population ranges from 1% to 2% in studies. And studies in STI clinics, the range is very broad. So some studies showing up to, a third of patients infected with Mycoplasma genitalium. What we're going to focus on today is that there's a lot that we know about Mycoplasma, but there's also a lot that we don't know about it. And, what we don't know, again, is that, for example, in the rectum, you can find Mycoplasma genitalium frequently in the rectum, but actually it has not been shown to cause proctitis. It has not been shown reliably to cause infection, for example. Right now, I think that there is quite a bit of different guidance from around the world about how we should be handling Mycoplasma genitalium. So, from the CDC guidelines from 2015, they said, you could consider testing men and women who are symptomatic, so urethritis and PID primarily. Guidelines from other places mostly also focus on testing symptomatic patients, although there was a European guideline for 2016 that said they would also test anybody with high-risk sexual behavior and also prior to abortion or IUD insertion because of the presumed risk with PID. So there is some variance about who we should even be testing.
So Mycoplasma genitalium, or Mgen, as we might refer to it during this talk, diagnostic testing for this organism is really challenging. So for most laboratorians are probably well aware of this, but it's good to communicate this with our clinician partners as well. Traditional lab methods that you might think of for microbiology are really not very useful for Mgen. Gram stain, for instance, is not useful because this organism lacks a cell wall that you're usually staining for with your gram stain, so it can look invisible or just very hard to see with a gram stain. Culture is also not useful. It's really only available in a few labs across the entire world, requires special media, and can take several months to grow, which is really not a clinically relevant time frame. The optimal detection method for Mycoplasma really is molecular testing, or that nucleic acid amplification NAAT testing. Next. So this has really exploded in the diagnostic field for the different test types that are available, really kind of looking through all the different things that are currently approved or in development. I want you to focus kind of at the top here. We now have 3 different instruments that have FDA approval for Mycoplasma testing. This is the Roche Cobas, the Hologic Panther, and the Abbott Alinity M. These tests can often test for multiple things. The Roche can test for both Trichomonas and Mycoplasma simultaneously, while the Alinity M can test for chlamydia, gonorrhea, Trich, and Mgen. The sample types, I think that they're really hearing us, and Mgen has gotten a lot more sample types collection methods associated with it than some of our past methods as it's been going through its approval process. We see both urine and swabs, vaginal, self-collected vaginal, endocervical, meatal, and even self-collected meatal. So the breadth of testing is really much wider with this. This has grown a lot over the past couple of years. Next. Another thing I wanted to point out on this chart is some tests that are in development right now that don't currently have approval in the US, but they do in Europe, is some tests that are also looking for resistance genes. And this is a growing problem with Mycoplasma. We'll talk about more. Next. So antibiotic resistance is a real issue with Mycoplasma. First, there's the natural resistance to things like antibiotics associated with biosynthesis, things that target the cell wall biosynthesis, like the beta-lactams, such as penicillin and cephalosporin. They're ineffective against this organism because it lacks that cell wall. And due to challenges of culture, since you can't grow it and do antibiotic resistance testing like you would normally do with other bacteria, it's really not clinically available, only in a research setting. So resistance is often detected by treatment failure or through research studies in specialized laboratories, but generally is not going to be available for your patients at this time. So if we can get those molecular methods that can detect resistance genes at the same time you're detecting the organism, that could be really helpful and something we should keep an eye out for in the future. Next.
So speaking more clinically to the problem of growing antibiotic resistance, there has been some really interesting studies questioning, are we increasing antibiotic resistance in Mgen when we presumptively treat urethritis symptoms with azithromycin? So for many clinicians out there, typically if a man's presenting with urethritis and we can rule out gonorrhea maybe on gram stain, so we're typically treating with 1 gram of azithromycin. And older studies show that in macrolide susceptible infections, that might cure up to 85%, although most recent studies show cure rates only about 40%, and that's because of growing antibiotic resistance. And in one Australian study, it showed even 80% of men who have sex with men in their clinic had macrolide resistant Mgen. And even more concerning is it showed that about 10% of Mgen infections that should have been susceptible to azithromycin actually developed resistance during the treatment with 1 gram of azithromycin. So we are potentially creating more resistance even just with our one-time treatment of NSU when somebody has Mgen. Now, doxycycline does not cure as much Mgen, but it does not cause resistance. So doxycycline, will cure about 30 to 40% of Mgen cases. We know it lowers bacterial burden, so actually symptoms may get better even if it doesn't fully clear the infection. But again, the benefit of doxycycline is that it doesn't at least cause resistance. Now, moxifloxacin is the typical treatment then for Mgen if it hasn't responded to doxy or azithromycin. And again, cure rates there in initial studies were about 100%, but more recent studies does show evolving moxifloxacin resistance as well. And additionally, with fluoroquinolones, there are some additional risks. So, again, we can't use moxifloxacin in pregnancy. It can cause quite a few side effects, diarrhea. There are case reports with fluoroquinolones of Achilles tendon rupture, for example, along with rare neurologic and cardiac events too. So fluoroquinolones are not without risks in and of themselves. So what to do? How should we be treating Mgen? Guidelines vary widely across the world. So the 2015 guidelines from the CDC at that time said, well, azithromycin either 1 gram or maybe a 5-day regimen. In Europe, the European guidelines really came out saying, well, definitely a 5-day regimen or using an antibiotic we don't have available here. Interestingly, the Australian and British guidelines that are more recent have used a strategy of using doxycycline for a week, so for 7 days, followed by high dose azithromycin. This is in macrolide sensitive Mgen cases, and they actually typically do antibiotic resistance testing. So if something is found to be macrolide resistant, then they just jump to moxifloxacin right away. But again, in Australia and Britain, they're using doxycycline, again, which may not cure the infection, but lowers the bacterial burden and probably makes it more susceptible then to the high dose azithromycin that they've used, that they recommend. So, it looks like I'm not in control anymore of the slides. Sorry about this. Let's see. Oh, there we go. So, this specifically is data from our Milwaukee Health Department. We started Mgen testing back in March of 2019. We started specifically screening men presenting with urethritis symptoms. So this is where really like the best and clearest data is that it is causing infection and that it should be treated, and that's male patients who have urethritis symptoms. So in our Milwaukee Health Department data, interestingly, over the course of 12 months, we had about 1,250 patients presenting with urethritis symptoms, and looking at the breakdown, and again, this is at our Keenan Sexual Health Centers, so our high-risk STD, urban STD clinic, the breakdown of infections, so gonorrhea was the most common, but actually Mycoplasma genitalium was more common than chlamydia in our population. So, because of that in our population, we've started treating all NSU patients with doxycycline for 7 days as the initial first line. We used to treat everybody with azithromycin just 1 gram because, again, in a high-risk STD clinic, you can watch them take it, you know they're taking it. But again, there's considerable concern that that's actually leading to more resistance for Mgen in our population. So we've actually switched to doing the doxycycline for 7 days. And that's usually when they present in our clinic with symptoms, we don't have the test results back. So we start treatment with doxycycline, and then if they come back positive for Mgen, then we add on a high dose of azithromycin at the end of this. Now, again, we can't test for antibiotic resistance. So if somebody continued to have symptoms, then the next line would be moxifloxacin. There's also pretty considerable variation around what we should be doing in terms of follow-up and treating partners. So, you know, should we be doing a test of cure? The CDC guidelines had said no. In Australia and Europe, they are saying, yes, we should be doing test of cure because of this issue of resistance. And then what about partner treatment? So again, the US guidelines have said you could consider partner testing. In other places, they do test and then treat for positive. And in some places they say, you know, just treat their current partners. You don't have to test. So again, there's a lot of variation in guidelines. I am hopeful the 2020 CDC guidelines are due to come out later this year, and I am hopeful that they will clarify some of these areas. But I'm not sure that they will. We'll see. So, you know, finally.
Sorry, I just wanted to jump in one little point on that last one. We were talking about test of cure and what does that look like in the laboratory? Generally, most laboratorians don't like to do test of cures with molecular tests because a positive PCR molecular method like these does not necessarily mean that the organism is alive. You could have dead residual nucleic acid being detected with here, and these kinds of samples can be residually positive long after the organism is dead and gone. So this is a hard one for laboratories to swallow to be able to do test of cures on these organisms. We'll see what CDC comes out and says.
Yeah, and again, I do think that's why the test of cure in these, where they do recommend test of cure, says, you know, really no sooner than 3 weeks after, or I guess some of them say, you know, no sooner than 2 to 3 weeks after you've treated somebody. Again, hoping that you will no longer collect genetic material that is just hanging out rather than causing infection. So, you know, again, Mgen is not the new chlamydia, and I want to be clear about that. While it certainly can cause some symptoms, we actually, you know, don't really, you know, we screen everybody for chlamydia, and I would argue against screening everyone for Mgen. This is, I think, the best worded in the British 2018 guidelines, where they said, you know, really the majority of people infected with Mgen do not develop disease. Again, as we've highlighted here, current treatments are imperfect and associated with the development of resistance to antibiotics. And finally, there's no evidence that screening asymptomatic people will be of benefit, and again, may cause harm at a population level. So, you know, there is some correlation between PID. There is no definitive evidence for, you know, a link to infertility, for example, like there is with chlamydia. So finally today, we're going to talk about trichomoniasis.
So Trichomonas vaginalis, this is our flagellated parasite in our mix today. It feeds through absorption and ingestion of bacteria and can survive in urine, semen, and water for up to 24 hours. This can be really helpful for some of our clinical diagnostic methods. Next. So unlike mycoplasma, we have lots of different diagnostic methods for Trichomonas. Microscopy has been used for a long time for early diagnostic ability, even within the clinic, putting a wet mount on from a vaginal swab. You can see that twitching motility and see it in there very quickly. However, it's not that sensitive. It's reported around 50 to 70% sensitive. Culture was a standard for quite some time. It's about 80% sensitive. It does take a little bit longer. And is still the gold standard for testing in abuse cases and very young patients. Antigen detection is also available. It has ranging variability. It's really not recommended for asymptomatic women. And molecular testing, much like our chlamydia, gonorrhea, and Mgen, has really gained a lot of popularity recently because it is highly sensitive and specific, and the samples tolerate shipping a lot better than trying to keep the organism alive in transport. It still takes about 1 to 3 days, but it does have the highest sensitivity and specificity. Antimicrobial susceptibility testing is not widely available. In rare instances, it can be found at CDC, but generally, drug resistance has not been a problem for Trichomonas to date. Next. So, male trichomoniasis is something that's really been gaining a lot of interest in the field right now. There is now FDA approval on 3 different platforms for urine testing for male trichomoniasis. The Roche Cobas, the Alinity M, and the Gene Expert all have this available now. It's not yet available on urethral swabs, but I think we can expect to see that coming soon. It is available on the self-collected I think we're going to start seeing it on other specimen types here soon. Next.
So, guidelines from the CDC in 2015 recommend screening for Trichomonas vaginalis in women with symptoms of vaginitis, also in people living with HIV, because again, Trichomonas infection will increase the rate of HIV transmission. And they say that screening might be considered for individuals getting care in high prevalence settings. So, for example, at the Milwaukee Health Department STD clinic, we do screen everyone for Trichomonas as well. What we know with Trichomonas is that there are significant racial disparities. So from this nationwide survey in 2013-2014, there was a sample of 4,000 men and women. The rate of Trichomonas in this random community sample was about 1%, but there was significant racial disparities. So broken down by self-reported race, trichomoniasis affected 7% of Black participants, while only 0.4% of other. And, the other thing about trichomoniasis is that it also skews toward an older population. So these are rates of STDs in men collected at various community and high-risk STD sites in Milwaukee. And it showed, and again, these were not always men who were symptomatic, so a mix of symptomatic and asymptomatic people. But in these studies, I want you to pay attention right now just to the gray bars for trichomoniasis. So for Trichomonas, you can see that with increasing age, the rates of Trichomonas, it becomes much more prevalent at increasing age as well. Looking specifically at our Milwaukee Health Department data, this slide we saw previously, I just wanted to highlight that in men presenting with NSU, with urethritis symptoms, just about 5% actually have a diagnosis of Trichomonas. So we know there are several important reasons to be screening and treating men for Trichomonas. Again, Trichomonas infection is strongly linked to increasing risk for HIV. In women, it has also been associated with preterm delivery, which we also know disproportionately affects our Black community. And again, by treating all sexual partners, by testing all sexual partners and treating all sexual partners, that is really how we're going to prevent recurrences and reduce transmission in the community. And again, with the especially high rates in our Black community, this is really important to reduce some of those disparities.
So I wanted to just summarize some of the work that we've done with lab testing. If you can go to the next slide. There are many different high throughput platforms available for STD testing. The ones I've pictured here, I've done a more in-depth comparison for the different test methods, available organisms, pathogens that they can test for. So I'm going to touch very briefly on the BD Viper, the Hologic Panther, Cepheid Gene Expert, Roche Cobas, Alinity M, and the BD Max. Next. Putting it all together, there are a lot of different pathogens that can be tested on these large, expensive pieces of equipment. Some are more than others. I think we've really focused today on the chlamydia, gonorrhea, Trich, and Mgen, but other ones to think through with both STDs and women's health, things like herpes, candida vaginitis, bacterial vaginosis, HPV, even things like HIV, hepatitis B and C, and group B strep for women's health. So these can be widely used for many different types of testing, which really optimizes the resources in the laboratory and can reduce the number of swabs or the complications when trying to send to the lab. However, I do want to also emphasize that it can be really complicated in bringing up this kind of testing. So if we're looking at by instrument and pathogen in this slide, we'll go to the next slide. This is looking by instrument and specimen type. And within each of these boxes, I've listed out all of the different pathogens appropriate for that specimen type on that specific instrument. Now, this is the best data I could gather current as of right now. It's possible some things are currently changing right now, but this comparison was really helpful for me to get a kind of a view of which instruments are able to do what kind of testing under FDA approval without having to do a lab developed tests. We're currently working on changing our test methodology here at the state laboratory. So this really helped to kind of set the stage and help us choose the best option for our patient population. Of course, every laboratory needs to make that decision for themselves. There's really a lot of options out there. Our current method is using the BD Viper listed at the top. This was a nice, inexpensive way to be able to test lots of people with limited resources. However, the specimen type and ability for this instrument to be sustained long-term, it is being sunsetted by the company. We really did need to move to something to be able to serve our patients the best that we could. So we've currently decided to bring on the Hologic Panther, and I'll talk more about that here in just a moment, but I thought this slide might be helpful for laboratorians if you're making similar kinds of decisions after seeing this kind of data and realizing what kinds of things are going to be available moving forward. I think there's a few things that might still be in the works, but certainly it's exciting to see things like male urine is now a routinely available specimen type on many platforms. Self-collected vaginal is widely available, and we're now seeing self-collected penile meatal available, oral and rectal. Next. So looking specifically at the State Laboratory of Hygiene, next. As I mentioned, we're switching to the Panther. So if you send us samples currently, as a quick update for you, how does this impact you? So over the next several months, we're going to be rolling out the different tests. As I mentioned, this does get complicated. Each test for each organism on each specimen type all has to be carefully evaluated in the laboratory to make sure it's working appropriately for you. So we're going to be sending out new collection kits. We're going to be able to test for additional pathogens we weren't testing before, like Mycoplasma genitalium. We're going to be able to test for other specimen types, sample types, like oral and rectal chlamydia and gonorrhea will now be tested in-house for a faster turnaround time. We're going to be able to offer self-collected penile meatal for mycoplasma, male urine for mycoplasma, and a clinician-collected panel that can test for multiple organisms simultaneously, which is a nice addition from what we already had. Overall, we should have a faster time to results compared to what we've had in the past because this instrument is able to do random access instead of large batches. So hopefully this will be overall a big impact, positive impact for your laboratory. I do want to emphasize that I try not to say this word through this whole presentation. COVID has really impacted our ability to bring on this testing, even just to get the instrument in-house and to get the supplies like the tips to be able to run the testing. So this is going to be a slow transition, and we'll be giving you lots of communications as we go along the way. Next slide. So how are we going to communicate all of these changes and make sure that you have the most up-to-date information? Well, we're going to start with this webinar. We're also going to send out newsletters to our clinical lab network, letters to each of the submitters who have sent us things in the past. We'll post announcements on our webpage. We'll have updates to our reference manual on our webpage, and we'll have presentations at STD conferences. We always like to collaborate with HCET, or we'll have handouts that can help you navigate the different specimen types and what they're appropriate for, and what's validated in our lab. Most importantly, I want to emphasize that communication between lab and clinician is so important for us, and we really want to be able to promote that. So if you have questions or concerns along the way, please reach out to us. We're happy to always start those conversations. Next.
So again, just to briefly summarize what we've talked about today. So for extragenital testing, again, if they use it, you should test it and offer rectal and pharyngeal testing if that's something that your lab can support. Self-collection, again, they may be more willing to test and you will find more to treat. In terms of Mycoplasma genitalium as a newer organism that we know is causing urethritis in males, again, remembering there's serious concerns with antibiotic resistance, and so thinking about who to test and treat is important. And again, for male Trichomonas vaginalis, it should be on your differential for men with symptoms of urethritis, and we should consider testing high-risk men without symptoms. Again, remembering this is more prevalent with increasing age, and there are significant racial disparities with higher rates in Black people. And finally, you know, there are many new FDA testing many new FDA-approved tests and updates at the Wisconsin State Lab. So we are happy to answer some questions that we have.
Sure, and I'll go ahead and read questions and then allow Dr. Dalby and Dr. Sterkel to answer them. Just as a reminder, if you're sitting there wondering how to submit a question, hover over the screen, look for the chat icon. Once you click on that, you can select all panelists, type your message in, and then just hit enter, and then I'll read it aloud.
I just wanted to mention at the end, we'll also have some information about getting PACE credits for all the Laboratorians. If you stay to the end, Erin will share you that code with you so you can get your PACE credits.
Great, thank you. Okay. I'm going to start with an FYI that was submitted in the chat box. This person says, I recently posed an Mgen question to the CDC and was advised that the 2020 CDC guidelines will be out in the fall. They also informed me that there would be a lot more Mgen information coming in the new guidelines. Do either of you have a response to that or just want to stick with the FYI?
I'll just say I'm really glad to hear there'll be more Mgen information in the guidelines, because I think that this has been a really difficult and unclear area as we've definitely struggled with this at the Milwaukee Health Department, thinking about how to implement this testing in a way that makes sense and doesn't increase harms.
Thank you. I'm going to go back to test of cure. I think Dr. Sterkel, you alluded to this, but there's a question about what method, concerns about residual nucleic acids.
Yeah, I think right now the only real molecular tests for mycoplasma, the only tests for mycoplasma really are molecular. So they are talking about doing test of cure with a molecular method. And I absolutely agree, Tom. Concerns with residual nucleic acids is certainly real. We don't have the best data to know when the appropriate time is. As Dr. Dalby mentioned, the current guidelines at other parts of the world are for waiting 2 to 4 weeks before retesting. I'm not sure if that's going to be appropriate moving forward, but we'll have to see what CDC says.
Thank you. We have a few questions regarding HPV. I'm going to read all 3 of them and then just let Dr. Sterkel and Dr. Dalby deal with that. The first one is, did I miss HPV in this webinar? Isn't it an STI for both males and females? And then finally, the third question is, could you touch on any advances towards testing males for HPV?
I would just say that Dr. Dalby and I wanted to put so many things in our talk today and did not have time for everything. We had to focus on, I think, some of the hottest topics that have come up recently, but we're certainly open to talking about HPV in future presentations, although I'll allow her to give her opinion on any HPV updates.
I would say, again, I echo what Dr. Sterkel said. Yes, HPV is an important STI in both men and women, but no, we did not touch base. We did not talk about that today. And I am not aware of any new testing platform updates in that right now.
Thank you. Any technologies for resistance testing in Mgen positive cases?
As I mentioned, there's a couple that are CE mark in Europe that are approved for testing for resistance genes. One of them can test for 5 different resistance genes simultaneously. I think some of the more common one, there's another one that's just testing for azithromycin resistance. As I mentioned, culture methods are not routinely clinically available for Mgen because of its challenges with culture, but hopefully we'll see more molecular methods looking for specific genes moving forward. Not currently any FDA methods.
Thank you. What percentage of population is showing Mgen treatment failure locally?
That's a great question. I wish we had that data. I think, we don't know. That's what I'll just say. I guess some of the problems that come up with this, just in thinking about this, is that, again, when we're treating with doxycycline, it's lowering the bacterial burden. And so people might feel better for some amount of time, and then we don't know when they have a recurrence of symptoms whether that's the same infection showing up or if that's a new infection. We are not currently doing test of cure at the Milwaukee Health Department. So I think that would be something that we would need to start doing. But even then, it's limited by, knowing what, in a high-risk STD clinic, knowing what actually is the same infection and not new exposure and new infection.
Thank you. 2 more questions. Is it possible to pool both at the clinic and at the lab? And the instance is if the lab has experienced a very high volume, can you take multiple vials from the same clinic and pool them?
Yeah, so there's a couple different approaches. As I mentioned, you can pool in the lab, which if you're going to be mixing liquids, we certainly recommend doing it in the laboratory in a very clean environment. So not only are you keeping your sample clean, but you're keeping the people who are doing the pooling in a safe environment, protecting them from any infectious diseases. But as I mentioned, there's different ways to do it. I mean, if you're using the same swab on multiple body sites, that's kind of a pooling method, and that can be done in the clinic. Or if you're collecting, 3 swabs and putting them in the same tube, that's kind of a pooling method that can be done in the clinic. All of these would have to go through study to be approved for testing. Please don't just start doing it on your patients. Please have a conversation between clinicians and laboratorians.
Thank you. And finally, can you remind us which self-collected swabs are available to clinics utilizing the state lab?
Currently, using our old BD Viper method, we do have testing available for self-collected vaginal, and we send out for oral and rectal chlamydia and gonorrhea testing. As I mentioned, we're going to be switching to a new test method soon, and we'll have many more options available.
Okay, and we actually had one more question submitted while you were speaking. Do you have suggestions on how to leverage the accuracy of molecular STI testing with insurance companies, as some insurances have started requiring prior authorization? That might be out of your scope.
Yeah, I have got a big Wisconsin oofta for that. Yeah, that is hard. I mean, certainly I would, just experientially in my clinical practice, I would say, again, we know that wet mount for Trichomonas is very insensitive. And when we do, we routinely now do Trichomonas NAAT testing and find a lot of infections that have not shown up on wet mount. So yeah, I would say, often when we collect samples, the way I typically do it is I will collect a wet mount and collect GC, chlamydia, and Trichomonas at the same time, but I won't add on the Trichomonas test until the wet mount comes back negative, because again, if you see flagellated parasites on a wet mount, then you've got Trichomonas. You don't have to do the NAAT testing on top of that. But it's when that wet mount is negative that getting that Trichomonas NAAT when somebody presents with vaginitis symptoms, in women at least, is really helpful. And again, the point today was really thinking about also testing men. And again, that, you can see flagellated parasites in urine, but again, the NAAT testing is really going to be better there.
Excellent. Thank you for your response. That is it for questions. I believe Erin has some announcements she would like to make, so we'll move on with that.
Can you go to the next slide?
I don't know that I'm in control anymore. Oh,
there they are. First of all, I just wanted to thank Dr. Dalby and Dr. Sterkel for sharing their expertise on this really important subject and for giving us such a wonderful presentation today. I also want to thank HCET for partnering with the WCLN to provide today's webinar. And if you're a Wisconsin laboratorian and you have any questions after we've concluded today's webinar, you can email me at the email that's shown on the slide there, and I'll be happy to forward your question to the appropriate speaker. Next. Okay, there was another slide in there about archiving the presentation. We are recording the presentation today, and it will be posted on our web page for today's event. And those in Wisconsin know how to find that information. There it is. And so there's the link to the web page that you'll be able to get to that archived presentation. It'll be there in a day or two. Next. And then I just want to share the information for obtaining the ASCLS PACE CEUs. Again, go to our training event webpage for this event, and there's the link. If you click on the link to the ASCLS CE Organizer website, that'll take you to the, their website, and then you're going to click on the box, whether you're a member or a non-member. And once you do that, it'll ask you to log in. So if you have an account, you log in. Otherwise, you'll need to create an account. And then you're going to click on Claim Credit at the top of the page. And when you get to the next page, you're going to look for the ASCLS State and Regional Events tab. And then you'll scroll down to the ASCLS Wisconsin and click on View That Region. Then once you get there, you'll click on the blue box to the far right for the webinar event for today that's listed. Scroll all the way down to the bottom of the offerings and click on Next. And then you'll finally be given a page where you need to put in the code. And the code for today's event is 2558. So that code again is 2558. And you'll be able to click on Next, and then you'll be taken to a program evaluation page that you'll need to complete. You complete that and click on Complete Survey, and you'll get to a page that allows you to download your certificate. And you can either save or print your certificate at that point. So I will turn it over to Carrie to conclude.
Thank you, Erin. I will just conclude today's webinar by thanking everyone for participating, thanking Dr. Sterkel and Dr. Dalby and Erin for presenting this information to us. And I hope everyone is safe and healthy, and goodbye.
Thank you.